Welcome back. So this is a continuation of Chapter 51's Caring for Clients with Diabetes Mellitus. And I am going to talk about another acute complications of diabetes, which is called hyperglycemic hyperosmolar non-ketotonic syndrome, or we abbreviate it with HHNS. So this is another potentially deadly condition that can develop as a result of infection or illness in people with uncontrolled type 2 diabetes, or when the diabetes medication aren't taken as directed. And some of you guys may heard of diabetic coma. So this is sometimes referred to that as well. So HHNS, some people refer it to diabetic coma. So this is also what we call more of a life-threatening condition, just like similar to DKA, but not 100% the same. All right, so the HHNC, what's different is it does not involve with acidosis or ketonemia. So there is no ketone, there's no acidosis, but the result of HHNC comes from too much glucose, diuresis, and dehydration without adequate fluid replacement. So this also caused their body to lose a lot of sodiums and potassiums due to the diuresis. And a lot of times this is more commonly occurred in older adults. The assessment findings we can kind of derive from the cause. So if we know that patient is dehydrated and diuresing, so we are expecting the blood pressure to drop, right? So hypotension is key, and because they're losing a lot of sodiums and potassiums and sugars aren't getting to the brain, then you're going to have some mental changes. Patient's going to be extremely thirsty, and that can cause your heart to pump a lot faster, right? Tachycardia due to lack of fluids, and sometimes fever occurs as well. So the other neurological signs include like paralysis, lethargy, seizures may occur. And if you guys think of some of the signs and symptoms for hypokalemia and hyponatremia, you'll notice that patient will have that as well. Okay, so patient will have poor skin turgor and also very, very dry mucous membranes. All right. So in this type of HHNS, patient's blood glucose level is way higher than the DKA. So DKA we talked about is from around 300 to close to 1,000. Here on the HHNS, the blood sugar level is from above 600 goes all the way to 2,000. So this is a lot higher. So what I wanted to see is to give you guys a comparison of DKA and HHNS. That way you can kind of see the difference, and hopefully that'll help you remember better. In comparisons to DKA, it doesn't mean, even though I put type 1 diabetes is up there under DKA, is more commonly in type 1 doesn't mean type 2 won't get the DKA. So that's a little misconception here. Generally for the hyperglycemic hyperosmolar non-ketotonic syndrome happens mostly in the type 2 diabetes. And again, the cause is inadequate insulin or oral hypoglycemic agents. Blood sugar level is a lot higher, 600, right? There is no, remember I said earlier, it does not involve with acidosis. It doesn't involve with ketones. It doesn't involve with ketones, yes. So there's not going to be any fruity smell or fruity breath. There's no ketones. The pH is going to be normal because there's no acidosis. There's nothing with respiration, no Kusumo's respiration like DKA. It's basically just shallow breath. DKA developed quickly. HHNS develops a little bit more slowly. You will see severe altered levels of consciousness because remember, what's another name for HHNS is diabetic coma, right? So patient's going to have altered levels of consciousness and profound dehydration. Okay, a lot more drier. Okay, patient's gonna have maybe some patient when they come in, their they have already lost their consciousness. They're going to feel really hot, dry, body temperature is going to be elevated for the hyperglycemic hyperosmolar non-ketotonic syndrome. All right. All right, some of the medical management. Let's think back. The cause is what? Inadequate insulin, right? So what do? We give them insulin, right? So think about the cause and then we can come up with a treatment, right? So administration of insulin. Secondly, patient is profoundly what? Dehydrated. What do? Give them fluids, right? And correct their electrolyte balance because patient in HHNS is hypokalemic and hyponatremic. So we're going to balance that electrolyte by giving patient additional electrolyte. Next thing is CVP is central venous pressure. Basically is a central catheter that you would put it into the patient and to measure the patient's hemodynamic response to the fluid replacement. So CVP is usually done in critical care or ICU units. So you won't see CVP in a regular hospital floor unless you go into the ICU. All right. So nursing management include, again, we'll be checking patients' blood sugar level, blood glucose level, assessing their electrolyte levels and whether or not the body is responding to the fluids that's been given. So checking on patients' hydration status as well and properly administer insulin per doctor's order and trying to monitor patients' response to the treatments provided. Other areas that we wanted to continue to assess include their intake and output, their skin turgor, vital signs, right? And to check patients' neurological status, whether or not patients able to regain consciousness, all right? Because if patient is lethargic, then the patient is also at risk for falls, at risk for injury. So as a nurse, you need to make sure you protect your patient's safety if you recognize that patient have impaired judgment. Okay, so that's it for this disease process. We're gonna move on to the next. There are three main chronic complications of diabetes. Number one is called peripheral neuropathy. I'm sure many of you have heard that before. Second one is diabetic nephropathy, nephro, right? So that's involved with the kidneys. And the third one is the diabetic retinopathy, so retinal, which is a word that means in the back of the eye, correct? So let's go ahead and take a look at the first complication, peripheral neuropathy. So the cause of peripheral neuropathy, or simply just neuropathy, is due to poor glucose control and decreased blood circulation to the nerve tissue. Now, this is most commonly with clients who are smoking as well as who are not taking care of their glucose level. So someone with peripheral neuropathy usually causes a lot of pain and there's decreased sensation to their extremities, which can also contribute to the development of diabetic gangrene. Okay. So we need to take a look at their motor, sensory, and autonomic neuropathy. Motor neuropathy, we're looking at their motor nerves, so how the muscles are weakened or atrophied. Okay, the feet is usually widened, and this can result in skeletal deformities, usually in their lower extremities, their feet, and their ankles. Okay, so as far as the treatment, sometimes it can get infected to the point that there's no way for this patient to heal, then the ulceration area or the affected skin tissues causing a lot more infection, and which eventually they will have to get a surgical treatment, which is amputation. All right, the sensory neuropathy, so this means patient may have feelings of numbness, which is also paresthesias, like tingling, burning. If they complain of needle-like pain in their feet and legs, this is the sensory neuropathy that we're talking about here. Now, if it's autonomic neuropathy, so this is a little bit different. It affects organ function that have several consequences. Think about what autonomic system controls, right? So it controls our GI system, it controls our digestion, controls our urination and bowel movements. It also controls our cardiovascular functions such as blood pressure. So if you know that patient is getting autonomic neuropathy, those areas will be affected. So for example, patient may have more frequent UTIs because they couldn't void, or they have less sensation and urge to void, which means they retain more urine and causing them to have urinary tract infections. Also, patient may have this neuropathy that affect their cardiovascular system, so they're having changes in their blood pressure and causing them to have hypotension or causing them to have chest pain, but because of the neuropathy, they weren't able to sense the chest pain strong enough for them to get treatment. So sometimes patient with autonomic neuropathy, because they couldn't feel it, they couldn't feel the chest pain, they delay the treatment, which means they may have to experience myocardial infarction and then go into the ER and then late treatment and couldn't get the treatment properly done ahead of time because of the loss of sensation. Additionally, patient may also experience problem with impotence or erectile dysfunction with the diabetes, and impotence is usually associated with diabetes because of the damage to the parasympathetic nerves. So it could be either male or female. They both may experience the orthostatic hypotension or bladder and bowel dysfunction as well. Okay, I've talked about many of the clinical findings. Now, what about diagnostic tests? So a careful and detailed assessment is important. We can check their neurological assessments and screening tests as well as the electromyography. We know electromyography is to test their muscles and nerves. So in patients who have these neuropathies, the electromyography may show a slower conduction of electrical stimulation along those nerves. So that's quite definitive findings. Again, medical management, I'm sort of repeating, but it is involved with careful diet, exercises, and controlling the blood glucose levels, and that means probably using the insulins as needed, several medications that can be used to reduce the pain. Could be anything from a antidepressant medication to more so the non-narcotic analgesics medication, and also anticonvulsant can be used. Many of you know gabapentin. Gabapentin is used for neuropathy, and that is considered a anticonvulsant medication. Okay. Next, I'm going to talk about diabetic nephropathy or nephropathy. Go to next slide here. Because of vascular changes in patients with diabetes, this can contribute to the development of renal sclerosis. And because of renal sclerosis, it can then progress to different stages of renal disease and eventually to the end stage renal disease. So a lot of patients with diabetes, eventually they undergo either peritoneal dialysis or hemodialysis as a result. Okay, so the diabetes can contribute to accelerated atherosclerotic changes in the blood vessels. Now there are 5 stages to diabetic nephropathy, stage 1 to stage 5, and those are listed in your table 51-5. I won't go too deep into the details of each stage. Please take a look and read it. Just like any other disease or progression of stages, in early stages, you don't usually see any obvious signs and symptoms. But because we know that kidney regulates fluid, so first we would notice swelling of their feet and hands. That's the most common signs and symptoms that we see. And this could be due to the loss of albumin, and which is a colloid that pulls the water into the vascular system. Because of fluid accumulation, we will also see blood pressure start to increase. Patient may feel a lot more tired and weak, so we will try to use diagnostics tests such as urine analysis to check to see if there's albumin in the urine. Okay. Again, we should know that BUN, or blood urea nitrogen, and creatinine, those are the measures of our kidney function, right? So if the patient is having diabetic nephropathy, then you should be able to see also BUN and creatinine correlating, and it will be elevated. Okay. Medical management involved with controlling the blood glucose level and also controlling the blood pressure. So we have several medications that we can use to control blood pressure. We have ACE inhibitor, which are going to end with prils like lisinopril or captopril. We also have angiotensin II receptor antagonists. Those medications end with sartan, like losartan. Those will slow the progression of the nephropathy. And patients should be recommended to stop smoking and also to reduce their dietary protein intake, because kidney is now not functioning at its fullest, and if you increase more protein intake, then it's going to damage your kidney further. Nursing management include, again, these are sort of repeating. We are going to continue to monitor patients' glucose level by checking the HbA1c level, checking their urine to see if there's any evidence of protein or albumin in the urine. And we want to continue to refer patient for smoking cessation resources and something like nicotine patch or nicotine gum to control their habits. And we need to talk to a patient about the progression of their kidney and encourage patient to come back and follow up. Okay. Next, we're going to talk about the retinopathy. So diabetic retinopathy involves also is a progressive changes in the microcirculation of the retina, and this can result in hemorrhages, scar tissue formation, and different degree of retinal detachment can also happen. Although this does not happen like abruptly, some patient with an average of 10 or more years from the time of their diabetes, they may start to develop retinopathy. However, if retinopathy starts to develop, then it can deteriorate pretty quickly. Okay. I am not going to go into the different types, the non-proliferative or proliferative, but I do wanted to talk about assessment findings. So obviously with the retinopathy, patient will have decreased visual acuity, will be more difficult to see things. Once they start to have vision changes, one of the most important thing is to report to the doctor, right? Blurry vision, or if they're starting to see something floating in their visual field, they need to talk to the doctor right away. Another thing is as far as medical management, so patient with diabetes should be checking up with their ophthalmologist evaluation. If they were first checked out by ophthalmologists and did not have any symptoms or signs and symptoms of retinopathy, they can repeat that every 2 years. However, if they do have a diagnosis that needs to be checked out more frequently, sometimes patients with evidence of retinal problems, they will be given blood pressure medications like lisinopril, which is an ACE inhibitor, and the one that ends with pril, right? ACE inhibitor. It can be prescribed so that it will help the blood vessels in the eyes get more dilated to improve more blood flow to that area. Lastly, just nursing management. So again, patients should be following up with their physicians and their treatment regimens for their diabetes to control their glucose. All these complications come from poor control of their glucose level, right? So that's one of the most important things that they should do. We should also teach them about the complications that can occur and encourage them to make appointment to look at to get their eyes checked out as well. Other than that, I think that's it for this chapter. This will end the chapter. Thank you.